As you know, this will be a question and answer session regarding the integrated provider system work. We had a pretty robust webinar yesterday describing the application process and providing that overview and training around the application process. But again, today will be a Q&A, questions and answers, to really look at what your concerns are or where you need further clarifications. Just for your information, there are 2 other IPS webinars that are already available on our website, which you can go back and look at, that we did approximately a month ago, which discussed more information relative to IPS. As many of you are aware, the Commissioner of Medicaid, Commissioner Azar, announced on Monday that there would be a delay in the implementation of the RCOs, and the timelines relative to all RCO events are affected, including IPS. However, all of that is pending CMS's final approval. We still do not necessarily anticipate any changes in the steps in the application that have been described to you thus far, although that certainly is possible until we get CMS's final approval. But I suspect it would be only minor at this point. How long the actual delay for implementation would be of the RCOs and any potential payment reductions that might be necessary because of our budget issues relative to this recent legislative session, those are being discussed with the governor, and I suspect that that you'll be hearing about that in the relatively near future. So that's not really the focus of today's question and answer session, though. Our question and answers today are meant to focus on the IPS program, and particularly around the application associated with the IPS program. And the focus of today's program is not the delay dates and the program, the overall Medicaid program funding. There will be future information about that, as I mentioned earlier. So with that, I'm going to turn this over to our Navigant associates and let them take the calls from here.
Good morning. This is Rahil Farah with UAB Health System. My question relates to the maximum amount of submissions that can be submitted by a single RCO. In reading the description, it appears that the RCOs will make decision and they cannot submit more than the amount allocated to them. So the question I have is, what kind of criteria? I know there's a whole scoring mechanism for the application. How would the RCO make decisions and prioritize these projects when they receive them?
Part of the process, the way it's been set up by the state, is for that actually to happen as you described it, for the RCOs to actually make the first line of criteria, or in terms of evaluating the projects. We've allowed, as you've indicated, that it to go up to the maximum. So if a region has up to, say, let's just use as an example, $30 million, and there's 2 RCOs in that region, we would receive applications totaling double that amount, $60 million or up to that. So we're asking the RCOs to actually screen those applications so that once they are received by the state, that we were hopeful to have those that meet the criteria, which is to match the goals of the waiver stated in the waiver.
So what criteria will RCOs utilize to screen those applications?
Well, I think you can look at the protocols. You can look at the application, and within that, it shows you the scoring process and ranges that the state will actually be using. So it would probably be best if the RCOs and providers, when considering submitting an application, that they're very understanding that, for instance, serving beneficiaries in the scoring process represents 25% of the score. So that would be an area that you would want to look at. I think the second highest and equal to that would also be the same amount, 25%, was the return on the investment and the ability to sustain that project over the long term after the funding has ceased.
So it's Medicaid expectation that the RCOs will utilize a similar scoring criteria?
That is correct.
Okay. That answers my question. Thank you.
Thank you for your question.
Take our next question from Angelique Andrews with Hoppy.
My question is, if you submitted a letter of intent to an RCO, and because you submitted to multiple RCOs, how do you choose which RCO to pursue to finish an application with? And if you say didn't submit to one of the RCOs and wanted to submit an application to that RCO because you thought it was in line with them more, is that also possible?
Angelique, this is Christina Coster with Navigant. To answer your second question first, it is still possible to work with any RCO to submit an IPS application with them, even if you did not submit a letter of intent with them. In terms of determining how to select which RCO to submit an application with, I think we would recommend, you can discuss with the RCO contact at each of the RCOs your proposed IPS project to determine which RCO will be supportive of sponsoring that project and which RCO is kind of most aligned with what you're trying to accomplish with your IPS project.
Just sort of an example of that is I drive into Montgomery every day. I see signage on the side of the road that tout, specific hospitals within the area that have specific expertises and have won national awards. The same is true when I drive home to Auburn at night. I see for the hospital in that area that they have signage touting some of the expertises that they have. So as someone that's maybe nearing retirement, I think about that occasionally. Where would I go for certain services? So I think that all of our hospitals have great strengths. Some have expertise that others don't, so that might be one of the criteria Christina had mentioned. Discuss that with the RCO and decide which may be the best fit for a particular area that maybe matches up with the RCO strengths also.
We'll take a follow-up from Raheel Farrow.
Yes, my question is, if I understand this correctly, that if I have submitted an RCO application, a project with one RCO, but later realized that I have an opportunity to work, another RCO, but if I have not submitted an RCO application through the other RCO, is there an opportunity to switch the RCOs, or it has to stay with the original RCO that you submitted the application with?
Yes, you would be able to switch to a different RCO if the other RCO that you had originally sent in your application to was not going to pursue it and not send it along to the agency.
Can you give a little bit more visibility? Thank you for your answer. That does answer my question. Can you give a little bit more visibility on type of capital expenditures that could be supported, through these IPS projects? An example will be currently if there's no mobile clinical services out there, and if an organization wants to create a mobile unit to provide services in low access areas where there's a high percent of Medicaid population, what is RCO's? Can you using that example, give us a little bit color on how the agency will look at those applications?
That's a great question, and we ask that you please submit that question to the RCO quality inbox so that we can further consider it and provide a response that way. And that will be something that we'll post through the frequently asked question document that's on the IPS webpage so that others can see that response as well.
We'll take our next question today from Barbara Stewart with Next Step.
Yes, thank you for taking my call. I just have one question. I need to confirm that prosthetics and orthotics are excluded from this program because it's a duplicate of coverage through Medicaid.
Prosthetics and orthotics, so just to kind of clarify the difference between the RCO program overall and the IPS program in particular, the IPS program is a component of the RCO program, but it's not related to billing for Medicaid covered services. Rather, the IPS program provides funding to support efforts to implement types of projects to improve clinical, operational, and financial performance in the RCO program objective areas. So just in general, a provider does not need to participate in the IPS program in order to receive reimbursement from Medicaid services. Specifically to your question about prosthetics and orthotics, prosthetics and orthotics are included as a covered service through the RCO program. So prosthetics and orthotics are included in the RCO program. Prosthetics and orthotics providers are not excluded from the IPS program. However, as was communicated yesterday during the RCO presentation, the agency is really looking for any provider that is participating in an IPS project to be able to demonstrate a significant impact on the number of beneficiaries served and or the total costs of the Medicaid program. So that's something to consider when considering IPS projects specifically.
Good morning. This is Gwen Williams. I'm actually sitting in on the call with Mayor. And my question refers to the 2015 Community Health Needs Assessment that was prepared by the Alabama Department of Public Health. It was referenced on yesterday. Will you be providing a link to that Community Health Needs Assessment?
Yes, we can provide a link, and we could also post it on the IPS webpage as well.
Marvelous. Thank you.
We'll hear next from Barbara Oliver with University of South Alabama.
Hey, good morning. We put in multiple LOIs on a project that we thought would be beneficial statewide. And how can we do this and just pick out one RCO to participate with?
So to clarify, the agency is asking for a single RCO region to only choose one RCO within that region to submit an IPS application with. The agency is not requiring to only select one RCO statewide, but only to select one RCO per region.
Okay, so we would select like our RCO in our region to put it in, but would we write it for the statewide? What about the other RCOs that we gave the LOIs to?
So if you would like to try to submit a statewide project, you would choose one RCO in each of the 5 RCO regions in order to work with to submit an IPS application. And I believe there is an area in the IPS application to note if you are applying for a statewide project.
Yeah, within Section 1 in the IPS application, there's a cell for you to fill in if this is an IPS application that's being submitted in multiple RCO regions.
We'll take a follow-up from Raheel Farouk.
Thank you again for taking my question. The question I have is, a big piece of our application will relate to the impact on the beneficiaries. And if we want to develop certain specialized program, we probably want to have an understanding of what % of the population will be impacted, Medicaid population will be impacted by those programs. For example, if you want to develop something related to mental health, what kind of information would the state make available to the providers who can really capture the impact as the number of beneficiaries that their program will serve from the state?
Yeah, this is Drew Nelson with the agency. We've been in contact with each of the RCOs and have developed a template of data that we will provide either by region-specific level or by the counties within each of the RCO regions. It'll be a summary of different aid categories and the number of recipients in each RCO region, as well as some additional general demographic data for the IPS plans. We will be posting that in the next couple weeks on the IPS website. If there's specific questions to what groups you're trying to impact, if the data is not adequate enough for you, I would suggest you contact that RCO specifically that you're partnering with to see if there's additional data that they can provide you, and they might send that request up to the agency as well. I would also recommend looking at Alabama Department of Public Health. Not only have they done the community health assessment, but they also have quite a few resources on the different needs within the communities.
Thank you. That answers my question.
We'll hear next from Mary Leslie with Carr, Riggs and Ingram.
Thank you. Will there be a formal process for notifying the providers if their LOI has been rejected by the RCO or by AMA?
Mary, that's a very good question. The fact that we're going to be able to have some additional time due to the delay, it'll enable the state to go back and look at that. We were under significant time frames, but to allow for that, I think the cushion, potentially a minimum of 3-month cushion with a delay, will give us a chance to go back where we can better orchestrate and make sure that if a project is submitted to a particular RCO and they're not, for whatever reason, choosing that they would notify the provider or providers in enough time that they can seek out other probationary RCOs within the region. Again, the state, encourages you to have very open dialogue with all the probationary RCOs, and there's a minimum of 2 currently in each region to discuss the project and to test the likelihood that they potentially will move forward with your project.
Our next question will come from Timothy Stone with Shilton Shelby Mental Health.
Yes. Will there be any limitations from the standpoint of Medicaid in regards to cooperation with federally qualified health centers?
I think if I understood your question, FQHCs are one of the provider types that has been identified throughout the documentation for IPS in STCs in the protocols and also in the applications, so that would be affirmative.
That there will be, that is an acceptable provider type.
Absolutely. FQHCs are identified as one of the provider types.
Okay. Thank you.
And we'll take a follow-up from Raheel Farrow. Please go ahead.
Yes, on the presentation on LOI submission top 10 most common proposed areas, you have provided that information on an overall basis. Would you be able to provide that information by RCO region so we can have some visibility on where the total proposed dollars are?
So I think we'll have to take that question back to consider. So that's, if you could also add that question to your email to the RCO quality email address, we will consider that question as well.
Thank you.
Our next question is from LaVoris Williams with L. Williams and Associates.
Yes, I was wondering, what's the time frame it's going to take for the RCOs to make connections with the providers that's trying to get in contact with a letter of intent to them? What's the time frame should I be expecting to hear back from an RCO?
Yes, within our presentation that was given yesterday, there's a timeline that's spelled out that sort of shows that. And we've already heard from various providers that some of the RCOs have already reached out with individual meetings or making those contacts. But we encourage you also in the presentation and other documentation for IPS, there are contacts. So if by chance you have not been reached by a probationary RCO, that you can actually reach out to them.
Precious Parnell with FEMA Pediatrics.
I hear everyone speaking about the LOI, the letter of intent is what they're speaking of.
That is correct.
We have actually received contracts from different RCOs and signed some and have questions about others. Are we a step ahead, or am I missing out on something that we're not quite aware of? Because we're actually receiving contracts.
Yeah, so there's actually 2 different letters of intent as part of the whole RCO program. I believe the letters of intent that you're referring to were letters of intent that providers are signing with RCOs indicating their intent to contract with the RCO. The letters of intent that we have been referring to in this presentation are specific to the IPS program and were regarding plans to submit applications for certain types of clinical improvement and other projects.
Okay.
And we'll take a follow-up question from Mary Leslie. Please go ahead.
This question is in regards to the application spreadsheet and the ROI calculation. Are these costs, the with and without implementation, should they be from the provider's perspective, the RCO perspective, or Medicaid perspective?
Mary, if I understand your question correctly, that would be the best estimate of a budget that providers and RCOs working together would come up with for the intervention, because in that return on investment, but also in the budget worksheets, that would include potential costs for the RCO for administration as well as the cost for the provider groups. So it would be a combination of both.
Okay. And then I have one other follow-up question, if you don't mind.
Yes, please go forward with your question.
In light of the forthcoming information regarding what is intended to be funded and not intended to be funded for these projects, if a provider has submitted a project that has different components to it, some of which we know will likely be excluded, can we still continue with those project applications and omit those components going forward?
Mary, we would encourage you to reach out and talk with the probationary RCO that will be sponsoring your project or potentially sponsoring. But yes, that seems to be a very logical step, that if there's components that would not be appropriate according to the guidance, that you would exclude those and focus on other areas.
We do have a question from Sheena Siggers with Pediatric Associates.
Yes, when is this integrated provider system application due?
The presentation, and there's a copy of it out on the website that was given yesterday, has a timeline in it that had a due date of July 1. And as Dr. Moon had mentioned at the beginning of this call and also yesterday, the commissioner, Medicaid commissioner, Commissioner Azar, announced earlier this week that there would be a delay. So we know that July 1 date would be pushed out, but that affords both RCOs and providers to use that additional time to collaborate on these projects moving forward.
We'll take our next question from Anna Velasco with Viva Health.
Yes, hi. This question is on behalf of Alabama Care Plan, a probationary RCO in Region B. Yesterday during the presentation, y'all had mentioned that you're revisiting or getting some further guidance from CMS about school-based services and whether or not those could potentially be funded through this project. What about non-emergency transportation? Is that something that's being revisited as well?
Hi, Anna. Thanks for your question. At this particular time, the state in the last 10 to 14 days has submitted that guidance to CMS for clarification. So I think that our stance on that is kind of remains what it was when we talked to probationary RCOs a couple of weeks ago that we're awaiting CMS guidance on that. So we'll be able to give you a clearer answer to that once CMS gets back with the state.
Okay, well, I had a follow-up question on your chart yesterday as far as what was a duplicate service. You have existing covered service such as family planning, case management, prosthetics, etc. That those would not qualify. I guess my question is, in a case where there is not access to such covered services in a particular region, and the proposed application would increase the access to an already covered service, is that disqualified? I'm not quite sure I understand what you're disqualifying.
This is Christina. There were a number of LOIs that appear to propose using the IPS funding to actually deliver, for example, family planning case management services, or to provide prosthetic and orthotics to Medicaid beneficiaries. So what was intended by that row in the presentation yesterday was that the IPS funding would not, its purpose is not to pay for actual Medicaid covered services.
Okay, but if the application involved creating the access to such covered services, then that's what you're looking for.
Right. Yeah, that's correct. Yes, increasing access to services would be is one of the RCO program objective areas, and would certainly be considered.
Our next question comes from Matt Holdbrooks with Kid One Transport.
Yes, as a follow-up to the question Anna asked regarding the non-emergency transportation piece, I was very engaged with the Alabama Department of Public Health Community Health Assessment in 2015. And one of the things that was identified is the access to care being the number one issue in our state. In particular, in the rural counties where there is absolutely no public transportation and no providers willing to serve those counties. The question would be, if there's not funding available to grow services through the IPS monies to do those things and provide those services, is there going to be dollars going forward that the RCOs would receive other than the per member per month funding to grow services in those areas? Because we have, in our 67 counties, we probably have pushing 40 that have very, very limited transportation, if not no transportation available.
Matt, thank you for your question, and I don't want to get too deep into this because it really relates to the non-emergency transportation issue that we've asked for some guidance from CMS. But I will tell you from the state standpoint, and we verified this with the state's actuaries, there have been dollars put into the capitation rates, or there will be in the most recent update put in, that would have dollars allocated for non-emergency transportation statewide. That specifically doesn't address, the lack of providers, but just like a number of other southern states that are very rural, a lot of those states, use various means of serving those populations. You have scenarios where a national provider comes in and works with local providers like yourself, with health department, with area aging, AAAs, and others to provide those services for the benefit of the beneficiaries. So non-emergency transportation is a Medicaid requirement, and there are dollars that will be above and beyond what the state has spent in the past compared to what other states in the region have spent on that. So there should be sufficient dollars there.
Moving on, we'll take a question from Peter Glazer of UAB.
Yes, I have a couple questions. One, just a clarification. The template that was just released for the application lists or requests a 5-year goal statement. Am I correct to say that the funding period is 3 years and not 5?
Matt, Peter, that is correct, that the funding period is 3 years, but one of the objectives of the waiver is to have these projects and interventions to be sustainable. So from the state perspective as well as CMS, we don't want to see these projects go away after 3 years. We want them to be self-sustaining. So that is the reason for the 5-year goals.
Okay. And yesterday in the webinar, it was noted that salary support is not an acceptable thing to include in your budget if it's for a provider that is billing for services. Is there salary support? Is salary support acceptable for other ancillary personnel that aren't billing for their service?
Peter, so that we address that appropriately, would you submit that question to the portal?
Okay. And then finally, maybe more of a comment, but maybe you can clarify for me too. One of the 4 major objectives listed as targets for our projects included improved access to and care coordination of health services. But according to the webinar yesterday, coordination of care will not be funded. So that seems contradictory to me.
Peter, this is Christina. So just to clarify that a little bit, the RCOs have extensive care coordination requirements, and care coordination is one of the major goals of the RCO program. So in terms of the IPS program, the agency does not want to provide funding for the same types of care coordination services that the RCOs are required to do in their contract with the agency. If there are IPS projects that are proposing care coordination types of services that go significantly above and beyond what the RCOs are required to do within their contract with the agency, then those would be considered. However, what we were trying to clarify yesterday was that projects that are proposing to do similar types of activities that are required of RCOs, those would not be considered for IPS funding because the agency is already paying the RCOs to do those types of things.
Our next question comes from Nick Lesson with HSI.
My question is, are DMEs included as an acceptable provider type?
So, yeah, this is a similar response to the question earlier about prosthetic and orthotics, an acceptable provider type. So they can be considered as an other provider, but again, the agency will be looking to provide funding to providers that can have that can have a significant impact on an IPS project and a significant number of beneficiaries. In terms of being covered by the RCO program, DME providers are covered services for the RCO program.
Next, we'll take a question from Meredith Hennessy with Consilius Group.
Yes, hello. So I think actually part of my question was answered already because it was, I had a similar question about the clarity around care coordination. So what I heard, and I'll just take this back to make sure that I've interpreted this correctly, that if there is a care coordination model that is you can make an argument is not being funded through the funding the RCOs have available, or sort of out proposing some type of innovation that would potentially be considered, but you have to be able to be clear about how it's something that's not currently being funded.
That's correct.
Okay. And then the other question I have is, so I also heard that the July 1 date is being pushed back, but we don't have a specific deadline yet.
That's correct. It's unknown at this time when the deadline will be pushed back to, but we will provide that information as soon as it's available.
Moving on, we'll go to Anna Velasco. Back to Anna Velasco with Viva Health.
Yes, hi. This relates to the question about if one RCO is not going to support an application, can the provider send their application to the other RCO? And that makes sense to me. I'm afraid, however, it's going to put the probationary RCOs in a position of everybody who submitted a letter of intent saying, are you going to support my application, before the probationary RCOs have all the information they need. Since we have a charge to only submit a certain amount of funding, the RCOs really need to have all of the proposed applications before them before they can make a firm decision. I could foresee a probationary RCO being able to definitively say, no, that's not the kind of project, we don't think that that's in keeping with the state guidelines, but it may be difficult in many cases to make a decision until we have all of the applications before us.
And I think that's a very good observation of the situation related to the timeline that we did have, where we had less than 60 days to. It's one of the reasons that I think, in collaboration with the probationary RCOs, that the state made the change that only one RCO would submit the application. I think what the pushback, probably minimum of 3 months, affords us, and we mentioned this earlier, is the state to go back and look at that again and come up with a methodology with additional time, where it would give the RCOs more time to evaluate the projects that they have. You probably already have most of them, since the providers submitted multiple applications to each of the RCOs, that you can go ahead and start your evaluation process of those that you believe would be the top applications that you could submit for your particular RCO. But to give the providers that feedback as quickly as possible. So we will look at establishing, the state will, a timeline that would give the RCOs extra time so that we could build that into the timeline for the benefit of both the RCO and the providers.
Yeah, I think that's good. And so when we talk about a deadline, I think being clear with everybody whose deadline is when. So the RCOs will need to set a deadline in advance of the deadline for that the RCOs have to submit the applications to the state, so that we can thoroughly assess things and decide which are going forward.
That's correct, and that is one of the positives for the delay that the commissioner announced earlier. Although we don't know what that timeline is, we assume that it would be a minimum of 3 months, but it could go to a longer period.
Next, we'll hear from Ernestine Tucker with Alabama Community Care.
Hi, my question is, can IPS funds be used for pilot projects?
Well, as has been stated previously, the agency is looking for these projects to be sustainable after the IPS funding ends, after that 3-year period. So I think there's different definitions of pilot projects. However, so being able to demonstrate that the project is able to be sustainable after the 3 years will be an important part of the project. However, I think pilot projects can help to identify projects that work well. So that is something that the agency is looking for, projects that will provide improved outcomes for the state.
But you have to demonstrate sustainability?
Yes.
Gotcha. Thank you.
Our next question today is from Steve McCabe with Hillcrest Hospital.
Yes, I have a technical question. I've not actually been able to review the entire application. Is there an opportunity to go ahead and submit the same application to multiple RCOs when you're completing it?
So the RCOs will be communicating exactly what they would like to receive from providers in order to determine if they will support that application. What we are asking, what the agency is asking, is for each provider, after talking with the RCOs in its region, to only select one of those RCOs to actually submit the IPS application to the state.
But if you're going to apply to other RCOs in other regions, would you have to rewrite the entire application again?
The application should be specific to each region. However, we would imagine that if it's the same project that you're submitting, that a lot of it would be very similar. But it should be tweaked and modified for each region.
We'll take a follow-up question from Lavoris Williams.
Yes, I have another question. Do you always have to be a provider for Medicaid in order to be approved by the RCO?
Yes, in order to actually receive IPS funding, a provider must have a contract with the RCO at that time. So and when submitting the application, you may still be in the process of contracting, but in order to actually receive IPS funding and work with an RCO to implement an IPS project, providers must have an RCO contract.
Okay, but you don't have to be Medicaid approved in order to contract with RCO. RCO would approve you that way through Medicaid? Is that what you're saying?
You also have to be a Medicaid approved provider.
Since we have a little bit of time left, the state did receive some questions that haven't been asked yet that we would like to go ahead and use this time to try to address in case someone had asked, and they may not be on the call, but this may be helpful to others. The first question related to the 10% contribution related to a work plan or project. And just to kind of review that it is required that the maximum funding that the state will do is 90% of a project up to $20 million. There had been question about what kind of attestation or proof of dollars to fund that additional 10% would be. The state does have in the application, once you get there, that both the RCO and providers have to attest that they do have the resources to provide that 10%, but the state has not put forth any additional requirements. For instance, we've heard from a couple of providers that an RCO had requested a line of credit for that 10%. That is not a requirement that the state has put forth, but that may be a requirement that individual RCO has put forth for their provider network. Just to kind of give an example, let's take for instance, if one of our state teaching hospitals puts forth a project through an RCO for the state to evaluate. Being a state entity, as teaching hospitals are, the state has public access to their financial statements so that they can see the resources that particular entity has. Where if it's a public entity or a private entity, the state wouldn't have that visibility. So the state does have the opportunity to go back and ask for additional information, but at this time all that the state has asked is for the RCO and the providers to actually attest that they do have the resources, the 10% minimum, to move forward with the project.
One other thing we wanted to touch on was the requirement that providers should only select one RCO that implements their project in a particular region. The intent here was to remove duplication and to reduce administrative burden placed on the RCOs. The other thing to note as well is the IPS project can still get credit for impacting Medicaid-eligible beneficiaries enrolled in other RCOs within the same region as long as the participating providers have a contract with the other RCOs at the time of funding.
We do have one additional follow-up question that comes from Ernestine Tucker.
The statement that you just made regarding the 10% and the state institutions, does that also apply to the FQHC?
Ernestine, thanks for your question. That applies to all providers. All providers and RCOs must provide a 10% contribution toward projects.
So if you have the visibility to look at the financial state of the state institutions, and of course the FQH fees. I guess they sort of work in the same way, but they're mostly federal funded. So if the state does not have to necessarily put up the 10%, does that requirement not apply to the FQH fees?
We didn't say that the state, to clarify, we didn't say that the state would not have to put up the 10%. In the example that was given about teaching hospitals, teaching hospitals would also have to contribute in collaboration with RCOs and the other providers 10% of the project. But we'd like to remind everyone that the PowerPoint presentation from yesterday, as well as the Q&A from today, is on the IPS provider website. You can find those links by just going to the Medicaid website and following links for RCOs, and you'll eventually get to the IPS page. We'd also like to thank everyone for their participation. I think yesterday and today we had a combination of maybe over 300, providers that called in and probationary RCOs. So we really appreciate the interest, and we look forward to the future of this project and what IPS will do. And also, I'm being given a reminder that if you have questions related to IPS, you can go to the IPS page, and there is a link that will take you to the address to send those questions.